On behalf of the next session, I'd like to introduce myself as Miss Miller's friend. I'd say it's quite a bountiful thing here to, no, okay, hey guys, I'm Chris.
So Toma's thrilled to welcome, I'll get, I'll get my act together. Of Dr. Still. Regardless of the patient, Dr. Stephenson applies Dr. Still's 3 principles. First, seek the cause of the symptom. Second, examine the patient with your mind's eye to look for health amidst the details of the patient's anatomy. And finally, restore vascular perfusion of the tissues so the body will heal itself. Dr. Stephenson is a published research physician, pioneering phase 1 studies in high-dose intravenous ascorbic acid in patients with advanced cancer. And since 2010, Dr. Stephenson has taught his program, A Day in the Life of Life, to medical students at osteopathic universities, residents, and medical staff at various hospitals. Dr. Stephenson abides by Dr. Still's mandate, osteopathy must be taught. Welcome, Dr. Stephenson.
Thank you. Well, thank you all for being here today. Who has seen me before? Oh, terrific. Please no heckling this time. No. All right, well, hey, I'm honored today to have my nephew with me. Chase, are you in the room? There we go. A fellow Chattanoogan, and there may be some of my other colleagues wandering in who live in the area. This morning, I'm honored to share with you some clinical understandings that I've picked up over 31 years of observation, experience. It's been remarkable what the body will show if you listen to it. And I can't believe how much I have learned since medical school from the people I've served. You know, you get some fundamental foundation pieces, and you just keep building on it and keep listening. And so today is a fun program. Betsy asked me to come up with something unique and original. So I said, well, let me see what I can do. So if there are any questions today, this would be an interactive process. If I know that there are those of you who are not in the daily grind of manual medicine, and that's great. That's fine. I'm a general internist trained out of Cook County Hospital, and I have been in a stage 4 cancer hospital for 18 years taking care of people. And irregardless of whatever atmosphere or place I was at, there was a place for touch. There's a place for healing. There's a place for just being human to human. So it doesn't sometimes matter what the technique was, it's that you were there and present with them to help relieve their suffering. So with that having been said, we're going to have an outline of the program here. Number 1, I'm going to give a little bit of Dr. Still's history and philosophy. It's really important to be grounded every time. Number 2, our first trauma, recovering from birth. Every program I give, irregardless of the environment, I'm going to go back and go, well, what was the original trauma? If we go back to the first problem, then we can build from there. Next is we're going to work on the focus of anger, the right 4th rib, sinusitis in the right thoracic inlet, post-mastectomy chest wall pain syndrome. I was the guy that Cancer Treatment Centers of America called on to repair women who've been damaged and injured. This is such a valuable thing that if you guys ever see a patient who has a mastectomy, women will handle 10 out of 10 pain with a smile. Men will handle 2 out of 10 pain with a grimace. It is so good to ask your patients who've had mastectomies, gee whiz, how are you doing? They'll tell you that, look, I roll around in bed for 90 minutes before I get to sleep. I'm up in 30 minutes to reposition, yada, yada, yada. So you will restore their quality of life by simply using these techniques today. The chronic kidney injury game, hide and seek. I can't tell you how many patients have taught me things about a remote pyelonephritis, a remote stone within the kidney. And then the 40 years of suffering they've had because that kidney never reset itself, that the parenchyma around the perinephric fat pad never reset, never released. So constant sympathetic loop. I'm going to show you how to identify that and fix it. Reactive airway disease in children of all ages. So I've done a lot of work in asthma recovery. And we're going to show you how to do that, the reason why. You've got to figure out why are people having reactive airway disease. Heartache in the left anterior chest wall. So many of us have anxiety and frustration. Many of us have lost dogs, wives, spouses, houses, and this troubled economy. And so I'd like to show you how to help relieve their suffering by simply lifting their heart. And then quieting the hypersympathetic state. This is my newest toy. It was occurring to me like a computer that if I can go in to the central nervous system, gently hold the body in a position of rest, segment by segment by segment, we can run off or get rid of the norepinephrine system that's causing such high anxiety. So there's my man, Dr. Still. He's a practical guy. That's not a staff. That's a 2x2 he's got in his hand. It's kind of funny. He was injured in a train wreck late in his life, and he walked with a limp after that. So that's his staff. The life phases of Dr. Still. August 6th of 1828, he had the birth. He was the third of 7 children in Virginia. He grew up on the frontier of Missouri. His dad was a Methodist minister, and so they went out to convert the Shawnee Indians to Christianity. So he was a son of the frontier, did evangelism, and then he was also a preceptor in medical training. So in September of 1861 to October of 64, he served the country and was fighting for Lincoln's vision of forever free without regard to race or color. That was his mantra. So since in the spring of 1864, as he's coming out of the war zone, he's coming back home. So now he's served his God, he's served his country, he's served his philosophy and his tenets. And instead of finding peace, he comes home, a chicken falls in the family's well. He boils his water for coffee, that's pretty much what he lived on. But the boys drank water straight from the well, and lo and behold, became very sick. His friends came, plied them with the medications at the time, and killed everyone in the house. Talk about post-traumatic stress disorder. I can't imagine what that would have been like to have been a father and a servant. And by the way, you're in the war zone, and you have no sterile field, you have no clean instruments, you have no morphine, you have no antibiotics, you have howling, screaming people without clean water or food to feed them, and you're somehow responsible to heal them. I can't imagine the heaviness in this man's heart. So in June of 74, he raises the flag of osteopathy. For 10 years, you don't hear a word from the guy. I've not found anything in the literature about what he said, did during that time. It's just deep darkness. So soon I saw the green islands of health all over the sea of reason. All the remedies necessary to health exist in the human body. In the fall of 1892, he opens the American School of Osteopathy, teaching 21 women and men. He's the first guy to include women in the medical program, in the medical training. So he opens the school in 92. In 97, he sees it slipping away. He sees people already eroding his philosophy. They want to be doctors. They don't want to be osteopaths. They'll give lip service to him about osteopathy, but they want the doctor title. And so he sees it slipping away, and he says, I've got to start saving my baby. And so he starts off with the autobiography. So in 99, he then writes, philosophy of osteopathy. The osteopath should find health. Anyone can find disease. In 1902, the philosophy and mechanical principles of osteopathy is published. The soul of man, with all the streams of pure living water, seems to dwell in the fascia of his body. In 1910, he produces Osteopathy Research and Practice. He is trying to be a Nobel laureate in this, and so each paragraph is numbered, paragraph by paragraph through the entire book. So it can be like a reference manual. So the book is respectfully dedicated to the grand architect. Any Masons here in the room? Any Masons? I'm a Mason, and our dictum is that we have to believe that something is greater than ourselves. Okay. And then we are to take care of widows and orphans. That's the two parts of the mandate for being a Mason. And all over his funeral, all over his tombstones are Masonic symbols. So when you go to Kirksville, you'll see that. So this book is respectfully dedicated to the grand architect and builder of the universe, to the osteopaths and all other persons who believe that the first great master mechanic left nothing unfinished in the machinery of his masterpiece, man, that is necessary for his comfort and longevity. So in December of 17, he passes away, and his last words are, "Keep it pure, boys, keep it pure." So here's my boy wondering about his femur. So Dr. Still wanted to be a philosopher. He wanted us to be philosophers, master mechanics, and diplomats of osteopathy who understood 3 fundamental principles. Number 1, seek to know the cause. The osteopath has his own symptomatology. He seeks the cause, removes the obstruction, and lets nature's remedy, arterial blood, be the doctor. Number 2, be a lifelong student of anatomy. The osteopath must remember that his first lesson is anatomy, his last lesson is anatomy, and all his lessons are anatomy. Today's program is based on my understanding of the lessons of anatomy and where things go. It's a neural network discussion, quite honestly. So number 3, the rule of the artery is supreme. The rule of the artery and vein is universal in all living beings, and the osteopath must know that and abide by its rulings, or he will not succeed as a healer. So think for yourself. That's what he wanted us all to do. Think for ourselves. He said that each one of us will define osteopathy in our own terms. So you must reason, I say reason, or you will finally fail in all enterprises. Form your own opinions, select all facts you can obtain. Compare, decide, then act. Use no man's opinions, except his works only. So today, I'd like to ask you to please use no man's opinions, except his works only. That's in regards to me. I'm going to show you my works. The human body is a machine run by the unseen force called life, and that it may be, may be run harmoniously. It is necessary that there be liberty of blood, nerves, and arteries from their generating point to their destination. So how do you restore the person after mental or physical trauma? Number 1, seek to know the cause of the dis-ease. Number 2, ask the patient, when were you last well? That is the key question today. If you guys want to take a note about anything, this is your key question. When were you last well? Number 3, you're going to reenact or repeat the event for the patient. Number 4, during the examination, bring the patient through the event. Your goal is to listen to the tissue and bring the body where it wants to go. And then number 5, you are the facilitator, not the source of healing. This is really awkward for me to turn away from you guys to read this, so I'm sorry. Maybe I can go somewhere else, maybe, I don't know. All right, so engagement, where the journey begins. I love this. So all of us, Dr. Still says, look, study normal. It is normal midwifery you must know. If you know normal midwifery, you'll be able to answer the other 2% that is not of the normal variety. So I did not understand how babies were born, and I had to study it. I was a home birth physician for some time, and we were upside down, and for those of you who are moms, typically you'll find the baby's bottom is over here. Every time they're going to kick you in the gallbladder and liver. And by the way, it's not in the slides, but for you surgeons, I'm not going to call you out, the 4 F's of gallbladder disease are female, blah, 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 blah. Okay, so my point is it's very derogatory and it's not fair. Women are being, why are women being in trouble age 40 for their gallbladder? Well, it's because for 20 years ago, they were kicked in their gallbladder and liver, and then over time, that diminished blood flow or trauma led to dysfunctional gallbladder function. I have a lot of empathy for my female patients for that. So, birth stages, it's going to be engagement, descent, rotation, extension, and restitution. So the baby's going to come down the canal. The baby, we are not delivered like this. Okay, this is the key thing. We are delivered in this fashion. We have to be streamlined. We have to be able to go through the passage as lean as we can this way. So if you want to know where neck pain, headaches, migraines come from, look at the 3rd cervical vertebra on the right-hand side. That is going to be a gold mine for those of you who are concerned that this is going to be where the otitis media resides. This is where dysfunction in the sinus tracts are. So we're going to come down, facing the pelvis here. That's normal towards mom's tailbone. The baby comes around the pubis, and then the head turns to the right side. So baby's face turns to mom's right thigh. And what happens? Well, it's not really a good indication of this, but so the baby is coming through, comes out, turns, the good doctor cleans the face, suctions the airway. But now the shoulder's caught on mom's pubis. This is a very important mechanical understanding here. So the baby gets torqued like this. This is where torticollis is occurring in the right arm. But this is also where the pivot point of the body is being positioned to get out. And it's such an incredibly difficult place. We'll talk about it in a minute here, but That's where that simple delivery process is what causes intractable back pain for babies. So, infant lab. So following the birth, examine the neonate in order to release the cervical strain, right shoulder, and enhance their lung function. And Laura's going to help us out here. So Laura has a baby, and I don't have enough babies for everybody. So this is my colleague here, Laura Pinnell.
All about the baby.
All about the baby. Okay. So what we'll have mom do, and whoever the caregiver as well, I'll have them hold the baby's thighs. Here's the baby's thighs. And so I typically will be down below the baby, and I'll place my left hand on the base of the sacrum here. You see that? It's the base of the sacrum. And I'm simply going to let the baby's weight carry him or her down. And I'll walk my fingers by each segment of the vertebra. The babies like this because this is what they knew for 9 months. And as you're doing this, you may even hear a loud pop or thump or whatever. It's amazing how many times. But when you restore the baby, all of a sudden, the baby goes to sleep. So baby, you want the baby to cry. You want the baby to open their airways. You want these things to come out. But the moment you turn them right back up, all of a sudden, they're very limp as a noodle. When you release the colic, you release the pain they're having, they like you. And so does mom and dad. So allow the newborn to arch their back and fully expand their lungs. So again, you want this to go on because a lot of kids get in trouble with a variety of different birth sequences. Even C-sections are not without their own dysfunctions. So by releasing the trauma of birth, you will prevent many possible complications and reduce the incidence of colic. Babies and parents will sleep better. So teach your patients how to perform abdominal breathing. Boy, this is hard. I'm trying to figure out how to, I want eye contact, and I have to turn away from you guys. This is not good. So have your patient inhale through their nose with enough effort to raise your monitoring hand on their umbilicus. Laura, would you mind being my volunteer again? So a lot of us get into stress breathing, and I'll have my patients who come in and say, I've got really bad neck pain, doctor. And I'll say, oh, well, let's just sit for a second. Can you show me, how you breathe? And so they'll be like, so they're using the trapezius, they're using other accessory muscles to pull air in, lift air into their lungs as opposed to the diaphragm to drop air in. So it's going to have you lay on your back, please. When I see that mechanism, I said, let's go back to being a baby again, because when you saw your child on the changing table, that tummy just rose and fell, rose and fell. And so we'll have them just take a deep breath, please. So this is the engagement of the diaphragm. This is the primary respiratory mechanism. You will prevent a lot of lost time and upset on yourself when you find that, okay, if I get them to stop repeatedly injuring themselves by getting them to breathe properly, physiologically, that neck pain goes away. All right, thank you, Laura. All right. I can't say enough about this. Instructing the patient to do audible inhalation, exhalation. The deeper the volume, the better they do. So you're inhaling great volumes of air so you can create a negative pressure within the lungs, which then provides greater preload to the heart to then circulate things. The solution to pollution is irrigation, and the solution to healing is blood flow. Okay, so we're going to get going here. The residual trauma and torsion in the adult. Examine the cervical spine, birth imitation, right cervical vertebra, and the basi occiput. And have the patient cough or swallow occasionally when you're working on their head or neck. Often patients will self-correct. Who would like to be a first volunteer here? No, not everybody, please. Anyone? Bueller? Okay. All right. Yeah, so I'll just sit right here for a second, or just turn that way. Okay. So what I was showing here, Michelle, thank you for volunteering. All right, so here's her right side. When I go to examine her, typically this is the third cervical vertebra on the right-hand side. You're going to find this is the 90% of your body's head's rotation comes through the first and second cervical vertebra. So in order that the head not spin off, the ligaments of the skull and cervical first two attach in the third, fourth, fifth, and sixth cervical vertebra on the lateral aspects bilaterally. But so the load is picked up on the third vertebra first, and that's what typically hurts. Thank you. And that. Then you'll see also that this right basic occiput can be involved. And again, we're going to come through here, come out, and then turn our head. Again, the right shoulder will be caught. So we'll go ahead and have you lay on down. All right. Do you suffer from migraines at all, or?
I used to, not really recently.
Okay. All right. What's that? She doesn't take insurance. All right. So just simply, I did not understand this as a medical student why always the left side of the neck was fine, but the right side is not. And you can feel right there. She says, please keep pressing there. Yeah. No, she doesn't. All right. So right there, I'm at the lateral transverse process of the cervical number 3. So we're going to introduce side bending and wrap around the tender point. And letting the body just roll out. I'm a one-trick pony. All I've got is counter strain. I learned everything else, but all I've got is counter strain now. So I'm not a big proponent of force, but we'll talk about that later. So do you feel that slowly melting away in there? Mm-hmm. So just gently positioning her and letting the body pick itself up and correct. By taking the load off the guarding tissues, the tissues that are all fired up and preventing further damage, all of a sudden they can relax. You give them a coffee break, and within very little time, they're ready to go. Now, interestingly, we were talking about, and I'll show this again in the other lab, but if you're really sexy, you can let the patient's head rest there, and you can move the arm to the side here and feel. Okay. 0 is no pain, 10 is the worst pain. What you got here?
6.
6 or 5? And right over here, again, same story?
Yeah.
All right, so this is that right shoulder I was telling you about. She gets caught on the pubis here. Now, we will talk about this further, but if I just bring the shoulder up in this fashion, and I'll have Laura typically assist me. So, Laura, you want to come on over a second? So I'm going to have Laura just hold 2 pounds of pressure just to support you so you can relax the arm. And I'll get down. So all I'm doing now is just 2 pounds. There we go. And it feels better if I move my hands towards your feet. Is that correct? Yeah. So I've translated my hands down towards your toes, and now I need you to do your therapeutic breathing now in through the nose and out through the mouth so that people can hear you in the back row. There we go. Beautiful. Keep going. Look at that. There. Do you feel that rib release? 0 is no pain, and all 10 is the worst pain. What is it now? 2. Okay, so we're going down. Nice deep breath again. There it is. So literally her rib is going back in place for the first time since she was created. Isn't that neat? Is that cool or what? 0 is no pain, 10 is the worst pain? 0 or 1. So from a 5, 6 to 0, 1. Once you release the body, it's not, I'm not doing this. She's releasing it. I just know where the landmarks are. But there, look at that. Is that beautiful or what? Okay. No pain here now? Beautiful. We're going to bring the arm back down. So the remarkable thing is that pain in your back. Does anybody ever have pain when they sit on a bicycle seat and they lean forward to try to hold the handlebars? Ever have that pain before? This is that pain. This is why you have that pain. This is also why when mom is trying to soothe us through the night, we're not soothable. And so we'll get up and nurse, but not nurse. We'll just latch all night long for 2 years. And because we're not self-soothing, there we go. There becomes a source of pain and anger because you're always in pain. You can't get rid of it. I took care of a pediatrician once, years ago, and I released that rib for him. And his wife came to me the next day saying, "What did you do to my husband?" I'm sorry, man, what do you mean? He's no longer angry. He's not angry when he gets home from work. He didn't yell at us. He did nothing like that. What did you do? I'm like, well, I released the source of chronic pain. Thank you for volunteering. Dr. Dilks, everybody. All right, counterstrain defined. Counterstrain is relieving the spinal or other joint pain by passively putting the joint into position of greatest comfort, or relieving pain by reduction and arrest of the continuing inappropriate proprioceptive activity. A lot of words. In other words, you are doing the work of the muscles that are splinting and guarding the injury. By allowing the muscles to relax, capillary perfusion is enhanced. All right, so here's my hand. Looks very attractive, very sexy. Got it? I won't show it too long. All right. Now, let's say I've sprained my wrist, sprained my hand in some fashion. That normal appearance goes to this. Now, do you see what color my knuckles are now? You guys can see the color? They're white, right? Hello? Okay. White knuckles? Okay, good. I want to make sure it hadn't changed. All right, so what you're seeing here is I go from proper perfusion to guarding diminished perfusion. It's like a sprained ankle. That's why it takes so long for a sprained ankle to get better. It's 6 weeks at least, and then you never really fully regain the use of it because everything has been locked up in splinting. There's no longer the injury, but everything acts like the injury is still going on. That same response in a leg is typical of a tooth extraction. It's typical of any kind of a trauma, punch in the arm, football injury. All of that momentum, inertia is stuck within us. So maintain stillness, roughly 90 seconds. Just position where they're in comfort. You didn't see there's any active motion on my hand or on my part. I did readjust when I was getting her rib going, okay, did it feel better here or here? And then just kept moving it to a position of comfort and ease. And then this may result in regional hyperthermia. Tissues get hot. Generalized hypothermia. What will happen is that the reperfusion process of damaged tissue will divert so much core fluid away from the other homeostatic mechanisms because now all of a sudden you've broken the dam and this blood comes rushing through. Well, it then causes generalized hypothermia, and I didn't bring a blanket with me, and I don't know why I didn't. I usually have to put people under blankets. My record is 4 in order to get them warmed back up. Otherwise, they go into the pediatric swimming event where mom said, "Get out of the pool," and you said, "No, Mom, I'm fine," and then you get out, you're blue, and you're shaking. Well, that's what happens here. So it's generalized hypothermia, untangled fascia, enhanced lymphatic drainage, like spontaneously. I'll hear sinuses like they're all, and then they're, hi, Dr. Stephenson. The relief of pain and fatigue, which may last 2 or 3 days. So this is a very important thing. People have been suffering for 20 years, 30 years, 40 years, or even 5 years who aren't sleeping. You take their pain away from them, and all of a sudden, they're exhausted. I've had to call people's family members to come pick up their loved one because all of the catecholamine events have stopped and the wakeful triggers are no longer there. And then they are not safe to drive. So a focus of our anger. During a typical birth, once the head and neck are delivered, the right shoulder is hung up on mom's pubic rami. In order to enter the world, the right shoulder is forced to rotate on its axis at the head of the 4th or 5th rib above the thoracic spine. Infants often have intractable thoracic pain that they are unable to self-soothe. Many of these babies will latch without nursing through the night for months. Many of us carry this pain into our adulthood, which can then be associated with irritability and short temper. All right, guess what? Lab 1 starts. Everybody stand up, please. And there are tables around the room here. If somebody could volunteers could grab these other 2 tables so there's more table surfaces to use, that'd be great. Chase, would you mind giving us a hand here? And Laura, we're going to bring some more tables to the back. And so please leave your chairs. I'm sorry, but this is an interactive process here. This is all about fun. So find a table, find 14 friends. And I'll have another volunteer up here maybe if somebody'd like to. Does anybody have right shoulder pain? How about that? Okay. Good to see you again. Thanks, Tim. Okay, I'm gonna do for the demonstration. If I have to do something else, okay. It'd be easier, yeah. Okay, so we'll have one down, please. Okay, just have you lay on your back, your head here, please. Okay. All right, so does everybody know Tim Bell? All right, Tim. So, Tim, I'm going to take your glasses off here for me. So, whoever's down on the table, we're going to go together. We're going to place that right hand of ours on the right side of the neck. So, you're going to try to examine through. Okay, is everybody, okay, so hands on the right side of the neck. You're going to feel the left side feels pretty neutral, right side. Now, by the way, people can have had injuries since they were born, so not every neck exam is going to be the same. But your goal here is to try to identify that third cervical vertebra on the right-hand side. Would you mind doing your collar a little bit? This is the tightest collar I've ever tried to work with. It hurt the guy. All right. So Tim, let's see here. Okay, that's not so good there, correct? Okay, so I'm not trying to be a jerk, but on the third cervical vertebra, this is what's interesting. I'd also like to have people who are C-section babies, who were scheduled C-section babies, because you will not find this on them. So I'd like to have, there's a volunteer who's had a C-section, or was a C-section, pardon me, scheduled. My older brother was C-section, and now I was the second one. Those people will have not this exam. It'll be entirely neutral. So we're going to place our hands on that third cervical vertebra. We're going to side bend to the right. This man was in the trades, worked his butt off before he said, I'd like to become an osteopath. So he really has worked so hard. So we're going to side bend to the right, please. Until now, you're gonna feel it'll slowly dissipate. There's you'll feel the fascia kind of move out of the way. And then once we've gone to the side bending to the right, then we're going to rotate to the left here. And in through the nose, please, out through the mouth. So you're needing to get your patients to make an audible breathing. So it's in through the nose and out through the mouth. In through the nose and out through the mouth. Does anybody have questions while we're doing this? Anybody have questions about how this is going? Does it feel okay? Okay. All right. So while I have Tim in this position here, I'm going to let him just rest for a second. Now, do you guys see his complexion has changed considerably? You guys see this? He's getting perfusion to his face. We're actually opening the avenue for the external carotid artery to do its job. Now we look at I'll bring you back to new for a second. All right, so if you look at George here, you come down, there's the fourth rib and the fifth rib, and that the head of the rib, as it articulates around the thoracic spine, is the hinge that causes this rotation. So in order to get out, that body has to rotate around that one pivot point, and that's where this pain in the back arises. Okay, so then we're going to go to that perivertebral, just lateral to the transverse process space, and we're going to palpate right to the spinous process, to the transverse process about the head of the rib. So any pain here at A or B or C? C. All right. So here he is at C. It's really going to be one rib. It's not going to be 14 of them. Oh, there are only, 12 on one side? So it won't be 14 anyways. But. All right, so I'm going to have Laura help me here. So I'm finding typically that if you translate the tissue above and below that fourth rib, in other words, if I translate they can move their shoulders easier. Now, he may have a torn rotator, he may have other injuries, but this is one key thing that all of a sudden relieves a lot of pain that people, thank you, that people are having. So who's down now? I want you to palpate along the left side of the neck. You'll see it's a different exam than the right side. Then I'd like you to place your hand on the right, from the occiput, come down, and you'll see if you try to balance left and right side, there's going to be a prominence on the right-hand side associated with that transverse process of the cervical vertebra. And if you press on it, they'll say, ow, that hurts. And you say, should I press harder? Does anybody not find that spot, that pain? Okay. All right. So then we're going to side bend the head to the right, please. And just simply go gently over to the right until there's a détente or a stop point. Once you've engaged that, then slowly rotate the head to the left. And this is where you start micromanaging. You kind of find, does it feel better this way or that way? If I bring the head toward the midline or back toward the right shoulder, slowly moving one way or the other. Your goal ultimately is to get that chin back to the way in which it was when the patient was delivered. So the chin will go onto the left shoulder. And you'll hold them there because once you can reproduce the injury that occurred, it'll allow it to reset and release. Any questions at all? Okay. So then, while you're doing that, if you have somebody else in the house to help you, that's great. You don't need to have somebody else to help you. But once you found that détente or that stop point, you can then palpate along the thoracic spine. Now, you don't have to do the neck and the thoracic spine at the same time. You can do them in different incrementals. But you're going to palpate along the transverse process, and roughly the fourth or fifth rib will be the most tender rib in their bodies. You will elongate the arm toward the head and translate the rib toward the feet. Have them breathe into it, and all of a sudden, the rib releases and goes into position. Some people will start saying just, okay, it feels like a weight has been lifted off my chest. I feel much easier, feel lighter. You'll hear people say, I feel lighter. Okay. All right, doing okay? I feel lighter. Do you feel lighter? Okay. He just says, I do feel lighter. I don't. Here.
It's easier to breathe.
Easier to breathe, feel lighter. Okay. Yeah, and so for those who, I'm very sincere because this thing has been locked all of your life. And all of a sudden, you can't self-soothe this. You can't reach it. It's just a punch in the spine. And all of a sudden, you get rid of that for people, and they're much more calm, comfortable. Okay, want to sit up? All right. Thank you very much, Tim. Oh. Well, here. Oh. Okay. There we go. All right. So where'd my clicker go? It's in my pocket. All right. So sinusitis and facial congestion. Who has sinusitis or facial congestion here? You guys have a nice allergy season, I know, in town right now. Anybody have sinus issues? All right, well, let's have you take a look here. I'm Chris. I didn't catch your name, please.
Deborah.
Hi, Deborah. Everybody knows Deborah? Thank you for volunteering. All right. So Deborah has allergies. And so patients often complain of recurrent sinusitis. Has that been you ever? Sinusitis? Sinusitis. Tonsillitis? Otitis media? No, okay. So patients may have postnasal drip, cervical adenopathy, and gastritis each morning. So what's happening is the postnasal drip is dripping through the esophagus and then down to the stomach, and they've been swallowing debris all night long, so they're feeling pretty irritable. So the superior vena cava and the right thoracic lymphatic channels are dependent on the anterior right second and third ribs for unobstructed blood flow to the right atria. I'll repeat that again. The superior vena cava and the right thoracic lymphatic channels are dependent on the anterior right, second, and third ribs for the unobstructed blood flow to the right atrial. So examine your thorax. Use your mind's eye to see the right impairment of the brachiocephalic vein and the superior vena cava at the second and third ribs. Okay. What's kind of interesting, do you see how the left subclavian vein comes over to the right side, then come back down? So it's got quite a stretch. If there's obstruction in through here, you put a dam in the highway, and it can't drain properly. So what we'll find here, I'm going to just examine just along the, okay, so here's the clavicle right here. I'm going to be in the midclavicular line, and I'm going to palpate here. See, that feels really great, doesn't it? No. So the reason she's got all this congestion is that she's got obstruction in the second and third rib. So far, so good? Mm-hmm. Okay, I'm just trying to make this applicable. You guys figuring this out here? Okay. Okay. Do you have a neck injury?
I have a stiff neck, but no neck injury.
Oh, you have a stiff neck, okay. All right, so we're going to bring your neck forward and bring your chin towards here. Now, if this is hurting you because you've got your own unique thing, please let me know.
Okay.
I'm not here to hurt you. They told me not to do that anymore. Yeah, Laura's going to, just for assistance here, if you have people in the room that can help you, well, then let them help you. And so Laura's going to provide like 2 pounds of pressure. There we go. Look at that. And nice deep breath, please, in through the nose and out through the mouth. So Laura really helps me as like my breathing doula. You know, I always have somebody, if she can help the patients breathe, then I can concentrate on what I got to do. All right, nice deep breath in through the nose, out through the mouth. Now, isn't this fun? This is getting to be looser and looser, isn't it?
Yeah.
Yeah. So look at that. Even your neck is loosening up. Isn't that cool? Yay. Okay, so slowly she's putting her ribs back in place. Now, nice deep breath. In through the nose. We can't hear you. Can you guys hear in the back room? Yo, you can't. Help me out.
Almost like
There we go. Awesome. There we go. I'm not hurting you, am I? Not hurting her. So there it's going. There it is. There it is. There it is. You feel that release in your rib cage? Beautiful. Now, beautiful. Look at that go. So she has an underlying, kind of a fascial restriction here in the cervical spine, but even that is releasing. Do you feel how the ribs are liberating in there? Did you see the color change in her face? I paid her to do that. There we go. Yay, that was beautiful. You feel the, oh, that's great. Okay, in through the nose now. How's your nose feeling?
Better.
Fair?
Yeah.
Okay, does that mean like better than before?
Yeah, better than before.
Better than before, okay. So, sometimes you have to work on the responses here. There we go, very good.
I need my glasses back.
Yeah, glasses.
Can't see.
Oh, no, I understand, ma'am. See, yeah, you're blind and now you're found. There you go. All right, so what we're going to end up doing with this, because we've got so much to share with you, we're going to do 2 labs at a time. So we'll see this, and then we'll do the next one. So we'll do 2 together. Okay. So here's Dr. Still again. He's a real proponent of everyone being trained in osteopathy. So the post-mastectomy chest wall pain syndrome. Has anyone had a mastectomy in the room? Okay. Laura, would you be willing to help me with this one? Okay. So patients may have decreased range of motion in the ipsilateral arm. That is, they can't look up here and they can't raise the arm above it. Patients may have insomnia and interrupted sleep due to the chronic chest wall discomfort. Depression may, due to the impairment and chronic pain, is often seen. This surgical complication, ribs stuck in inhalation, may be prevented by avoiding having the arm above her shoulder, not using a wedge under the scapula, or having time-outs during the surgery in order to reposition the arm. So I had to explain to surgeons repeatedly, this is how we prevent the problem. This is how we prevent the problem. I'm tired of fixing the problem. So I'm going to have, this is where you'll typically find it, just lateral to the costochondral cartilage, and then kind of following the lateral after to the anterior axillary line. So I'm going to have people one up, one down, please. And we'll go through this real quick. I'm going to have the release of the, guys get mastectomies too. So Brian Piccolo, you guys know who Brian Piccolo was? Yeah. So, all right, come on, guys, help me out here. Don't just sit here and watch. I need you guys, come on. I'm not going to hurt you. No one's going to be upset. So, let's see. I don't know if, can you guys see, is the camera on right now? Is it broadcasting there behind me? No. All right. So, your landmarks again, you're going to look for the midclavicular line. Typically, it's the second, third, fourth, but typically not the fifth. Vertebra to the side. So out to the anterior axillary line. So this is your landmarks. Your goal is to find out what hurts the worst. This is like an MD kind of a thing. Oh, it hurts here. Oh, we'll fix it here. This is one time where the arc of the radius is where you got to go. So you'll place support of the patient's cervical spine. Let's just say she had one here at the third cervical vertebra and the mid-lateral sternum. So we're going to bring that chin forward toward the costochondral junction. There we go, and have the patient breathe. And release. So literally, you'll feel the cartilage release, and with it, the rib goes back in place and the pain goes away. It's that simple. This is a counterstrain approach. It does not require force. It's gentleness, and the patient will correct themselves. So we have that. Or then, let's say it's the anterior axillary line that's involved. You would simply go out along here, and rather than being forward flexion, side bending is the corrective positioning, more so for this. And examining the third rib. Again, you're just going to palpate the rib cage and find out where the most pain is going to be. The sweet spot for this is typically between the second, third, fourth, and fifth ribs, typically not below that at all. Here we go. Okay. Now, as I'm doing this, I just want you guys to know we're all doctors. Your patients suffer. People won't talk to you about this. Your patients won't say anything about this unless you bring it up. I'm showing you this so there's a solution, because I know you're all very compassionate people, but please don't be awkward about these things. This is about how to help people who are in a lot of distress. So, any questions about how to release that? What's your question?
Used for someone who's nursing and has had mastitis?
The question is, can this be used for someone who's nursing and has had mastitis? The answer is yes, and I don't want to get into this right now, but there's smooth muscle in the mammary tissue as well. And putting the chest wall into position of ease and then finding out, we've done manual exams before, and you find out what is tender for the chest, what's tender for that mammary gland. You then, like any other counterstrain approach, you would bring that mammary gland into position of rest and comfort, hold, and let it release. It will drain the ductual on its own. So whether it's draining to the internal thoracic or to the axillary line, typically you'll find 70 to 80% of the pathology in a woman is going to be in this talus spence up over here. That drainage section is where they're going to get the greatest relief. Meanwhile, I've seen them, though, along the 9 o'clock position as well, and just simply translating the mammary toward the midline and making micro adjustments will allow that to release as well. So I used to do a home birth, you know. You've got to be able to meet people where they're at. All right, anybody have a question about this? Okay. Then I'm out of sync here. What was the one I just showed before this one? Laura, sinus. Okay. Anybody have a question about the sinuses? Very similar approach here. You're going to look to the chest wall, and you're just decompressing. Okay. So now I put down the clicker somewhere again. Oh, it's right there. Thank you. Okay. So nobody has a question on this? We're okay? If you guys never need to do this, great, but I want you to know at least you saw it once. And a lot of this is you see it once. That baby lab that I showed you is really near and dear to me. It was the very first convocation I attended in Dallas, Texas. Viola Fryman, a very famous cranial osteopath, was up there teaching. That woman so inspired me that I said, for the rest of my life, I must share this wisdom. I must share this wisdom. So though I never held a baby until 3 years later, that teaching stayed in my mind. I'm hoping to do that with you through this program, that you at least saw this once. And if you never need to see it ever again, wonderful. But if you do, you can be a source of healing. Okay. Restoration of the body does not require force. One man advises you to pull all bones you attempt to set until they pop. That popping is no criterion to go by. Bones do not always pop when they go back to their proper place, nor does it mean they are properly adjusted when they do pop. Research and practice. Okay. This is key. This has been my greatest discovery. I had a lady come in just last week, bilateral pyelonephritis, 42 years ago, with the second child she was carrying. Since that time, this woman has been diagnosed with spinal stenosis, arthritis, the whole panoply of gastrointestinal issues, gynecology issues. She's had 4 MRIs, I don't know how many CT scans, ultrasounds, nice lady, mother of 2, suffering since the second delivery. So has anybody had, okay, come on, somebody in this room has had a kidney stone. Somebody's had a pyelonephritis. You've already volunteered. I need somebody else. Come on up here, young man. I'm Chris.
Sid.
Hi, Sid. You guys give Sid a nice round of applause, please. All right. So Sid, where was your kidney stone?
I've had them both sides. I've had like 5.
You've had 5, both sides?
Yeah,
Oh,
left and right.
left and right, okay. So he's had left and right kidney stones. Okay, so you guys remember how to diagnose pyelonephritis? Don't get up there yet, Sid. All right. So you guys know like pyelonephritis, like how to be a jerk in the emergency room? So you have your patient, and you're going to just tap on that kidney, or you're going to tap on the kidney. All right. If you have a hot kidney, that hurts like heck. So let's have you lay on your back. So what's wild to me is how the war in the Pacific was over, and for many years after, people thought the war was still going. Well, this is that Pacific discussion. So the pain of the kidney stone and or pyelonephritis can cause a significant sympathetic guarding response that does not resolve entirely after the successful treatment of the stone or infection. Patients may have pain in their abdomen or back for decades after the episode. Many ultrasound, CT, and MRI scans ordered for the back, abdomen, or urologic symptoms will be non-diagnostic. So you guys know, please give me a break on this one. It's a retroperitoneal structure. It's at the very bottom of the thoracic. Again, this is the wonders of the thoracic. So give me a break. I'm going to call it in the thoracic. So, but what's really wild is all of this tissue around that kidney is designed to protect this vital organ. At all costs, we got to protect the control of the internal ocean. That was a revelation to me. The kidney is it's a controller of our internal ocean. So at all costs, tuck it in, pack it in, make certain that it's guarded. So I just showed one side here, but I'm going to just palpate. Sid, I'm going to just bend your knees for me. Just drop your back. There you go. So okay, a little bit right there. Yeah. It doesn't feel so good. Yeah. And I'll go over to, because it's that bilaterally. Oh, and by the way, I'm just going to go over here. And nothing really there, correct?
No.
Okay, so I'm right in the 11, I'm in the 12, T12L1 region here. And he's really pretty benign, but there's enough there, he says, yeah, that doesn't feel good.
Yeah.
It doesn't feel good. So we're going to go on, you're always worried about your volunteers, like unchecked, gee, I sure hope the guy has it. All right, so I'm down now at L4, nothing really going on there. And then far worse on the left side. So how long was when was the last stone you had?
It was on my right, I think 2020.
2020. So the last was on his right, 2020. We found signals of it from 3 years, and this one is hotter, and that was more remote, like 8 years ago or something like that?
Probably 5.
5. All right, so without realizing, he's learned to live with a 5 out of 10 pain, or whatever the pain has been, just smoldering in the background. He lives with it. He goes, oh, I've got back pain. Every so often my back goes out. And no, actually behind all of that is the kidney. Let's see. I'm going to be advancing to the, yeah. All right. So what I'm going to do is reach with my hand up underneath the T12L1 area. I'm going to cup that perinephric fat plane in my right hand. So far, so good? I'm then going to hold it, try to take off the pressure from the renal artery. Translating it in, I'm taking all the load off the suspensory ligaments. Whatever I can do to unlock the suspension system for that and give it support, that's what I'm going to do first. So far, so good? Guys, I know it's a reach, okay? Just hang in there with me. It works. All you need to do is have faith in yourself. So we're going to, okay, right there.
Yeah.
Pretty good. All right. If I go in toward the spine, that feels better, correct?
Yeah.
Yeah. So I'm now taking the load off the renal artery, the renal vein, the suspensory ligaments. I'm simply just holding the perinephric tissues in my right hand. So far, so good?
Nice and deep in through the nose, and push it out through the mouth.
Okay. All right. Now, Sid, if I translate my hand up towards your head or down toward your feet, which feels better for you?
The head.
Yeah. Typically, that's what it is, because the gravity has been pulling that kidney down. The more gravity pull, it's just straining on the ligaments again. So you're going to, again, cup the perinephric fat tissue and just translate that. Translate the tissue up toward the head, diagonally toward the spine. So up and toward the midline.
Take a nice deep breath in through the nose, push it out through the mouth. Continue doing that.
Now, when this becomes really important to you, you study urology, you go, okay, well, the pain that's here in the kidney, by the way, is also in the renal pelvis and in the ureter and in the trigone. So just for sake here, I'm going to, the ureter is just lateral. It's just like running right anterior to the spinous, of course, I need the lateral process. What do you call that? The lateral process of the spinous process in the back was the one on the side. Transverse, the transverse process. So just anterior to the transverse process of the ureter is going to be traveling along. So there we go. Now, there we go. Look at that, Sid. 0 is no pain, 10 is the word. You feel it just released this then?
Yeah.
Yeah, all of a sudden, the kidney just dropped in my hand here, and there's no more pain.
Nope.
This is earth. This is like really changing for people's lives. yes, it's going to be encouraging to get, do whatever it takes to avoid further stones, like drinking water, depending on the etiology of the stone. But I will literally work with the kidney, then I'll examine the track of where the ureter would be, and then go down to the trigone. The reason this is important is that many people also have problems with enuresis, all night long. The guy have to pee 3 times a night. It's because this irritation of the kidney is sending signals down the ureter to the bladder saying evacuate, evacuate. When you find that as well, again, this is not a part of the program, but relax, 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 relax. So I'm on the lateral trigone of the bladder, and I'm just simply releasing here. I'm going to hold my hand over, and you see that releasing in there? Look at that. Yeah. So if I do the work of the peripelvic muscles that are supporting the bladder, again, this is not a part of the program, but I thought, what the heck, I'll show you guys anyways. I like it that much. There he goes. Just relax, there he goes. That's it, that's it, okay. Any discomfort there now? No. It's really good, okay. All right. Again, because I like sit, I'm going to have you flip around real quick here. On your knees. So again, I'm placing my hand just between the 12th and the first lumbar vertebra, 12th thoracic, first lumbar. I'm going to hold, support, cup, translate toward the midline because I know I'm trying to get rid of all the tug on the renal artery, renal vein. Then I'm going to translate up and down because this has been hanging there so long. There's strain on the perinephric tissues. So translating the kidney up toward the shoulder typically is the best way to go with it. If you don't know what else to do, translate it that way. Because they'll then say it feels better. And you're going where it wants to go. There you go. Okay. Right there doesn't feel so good, right? Yeah, okay. So I'm going to move my hand. Again, it's the palm of my hand. I'm just going to translate my thinner eminence toward the midline to that spine. We're going to translate up toward the head and support. A nice deep breath in through the nose and out through the mouth. What's interesting is like the kidney's the beacon. It'll send all the signals down line. And once the kidney heals, once the war's over at the kidney, it'll send the healing signal down to the ureter and the bladder so that spasm will decrease. But you can accelerate by just doing what I just did there to cradle the knees, take the load off the external obliques, get the pelvic tissue to release. Is this fun for you guys? I mean, you guys kind of novel, kind of different? I'm a general internist, so don't give me that crap. I know what it is. Okay. Okay, feels good? Yeah. Okay, so then I'm just going to examine the lateral trigone, ipsilateral trigone. Just relax, relax. And just like kind of, just screen, make sure this is cleaned up as well. I want this man to be able to go to bed tonight and sleep all night long without having to be awakened for some other, reason. Nice deep breath. And so what will happen is, as it releases in the pelvis, you'll see the legs translating further and further. There it goes. Isn't that neat? Yeah, and so he was breathing, breathing, breathing. All of a sudden, the pelvic mantle where the bladder was suspended lifted and released. Okay. Thank you very much, Sid, for your help.
Thank you.
Okay.
After each stone passage, the technique must be repeated. So B, that's another stone.
Yeah.
Passing.
Yeah, you should screen for it. I mean, because what's happening is that every time you get punched in the kidney, you're doing one of these things. And so you get to where you're not in pain anymore, but you're still 10%, 15% residual discomfort back there. So the body's always kind of like wincing. This is part of the hypersympathetic response too. You got chronic pain in your spine. Your threshold for tolerance for things diminishes. Again, women can handle a 10 out of 10 pain problem and be able to give you 3 answers to any question you ask them. Men who are in that kind of pain can give you 1 answer. Damn it, I told you what the answer is. Okay. Does anyone want to try that? Check that out? Anybody else with a kidney stone? Pyelonephritis. Anybody with pyelonephritis? It's the same issue. It's the same issue. People are in a lot of pain, back spasm going on. They're trying to guard. It just doesn't release. Would anybody else like to try this? Bueller? Anyone? Okay. Does anybody know Betsy Hill, by the way? She's not just your champion. This young lady is in Washington State. She's in Minnesota. She's in South Carolina. She's doing all that she can to be a supporter of this organization and profession. So if you ever can get a chance, check in. Hey, Betsy, how you doing? Can I be helpful? Can I help you spread the word? She's your hero. She's looking out for you. She's got your back. She wants to make this program remarkable. If you have any suggestions, please share them with you. Do you guys ever go into somebody's house and you go, what the hell? The wallpaper's falling off the corner of the house here. Do they not see that? How do they not see that? Well, they don't see that because they're in the house. They don't see it. I would like you to give Betsy feedback that says, you know, hey, I have a friend who really would like to see this, and if I could just tell this is going to be available during the conference, I know they would come. You know, just enhance whatever we can do to make this better. That's what she wants to hear about. So one thing, too, I was sure, any fellow APIS in here in the room? Anybody APIS? Any APIS? Love it. Oh, that's right. All right, so that is, we have apiaries. We have bees. This lady's young man has, how many, 28? Yeah. So let's start off as a sideline thing is now, Mitchell has a number of hives. If you guys want to be humbled, if you want to be humbled by, damn it, how did I miss that? Well, become a beekeeper. So, so at any rate, I'm humbled. I've been doing this for 10 years because of my wife's sinusitis. Allergy, immunology issues, you give passive immunity by giving raw local honey. And so for my wife, I've become an apist so that I can learn how to give my wife raw local honey so that sinusitis is not an issue for us anymore. As a doctor, it's really terrible when you can't help your wife or your family. You know, you're always like 2 left feet and you can't figure out how to solve any problem. Well, the bees take care of it for me. So, all right. So we find a great power and use in the pressure of the lungs when filling on arterial blood to drive it through the system and a vacuum to receive venous blood when air escapes. That has been held in the veins by valves which keep blood from being pushed back while the artery is being aided by pressure to supply all parts of the system. I understand Dr. Still isn't easy to read. Okay, I understand that, oh, he's very intimidating. He's a philosopher. He's great. So philosophy, mechanical principles, osteopathy. So this is key. Once you label me, you negate me. Who do you guys know Soren Kierkegaard? Kierkegaard, anybody? Liberal arts? Come on, guys. All right, who's familiar with the expression? Once you label me, you negate me. Oh, that patient's got psychosis. Oh, that patient is whatever. The patient has this, and therefore I just give them this. So again, I'm Cook County trained. So you come into my ER, I'm going to give you, springtime typically, worst season, I'm going to give you 40 milligrams of prednisone 5 days in a row. I'm going to go ahead and give you all the beta agonists you can handle and have you with a pipe in the ER until you settle down. Because after all, it's asthma, daggone it. So all that wheezes is not asthma. So reactive airway disease in children of all ages. That means I'm a child. We're all young. So this phenomenon is associated with viruses, allergens, pollutants, bacteria, weather changes, and dust. Airway hyperresponsiveness may lead to mast cell degranulation and inflammation with IL-4, IL-5, IL-13, associated pulmonary spasm, and air trapping. So these guys can't blow the air out. You guys know that? Like, they can't exhale. They're like COPD. They're all locked up. But why? Why is this going on? So reactive airway disease. This condition may be related to cesarean section, premature birth, or delivery under anesthesia. I've seen all of these conditions. Many of us start life without taking a full, lung-expanding first breath. Without fully inflating our lungs at birth, residual defects in lung volumes of VQ mismatch occur. To optimize your patient's vital capacity, hyperextend their thorax over a pillow at the end of the examination table. And of course, I don't have a pillow. Daggone it. I'm going to use my toe. Okay, encourage the patient to take deep breaths. Audible breaths during the examination of their ribs will inflate the lung. So what are we doing? Okay. Do you see this cornice? It isn't a round dome. Same thing here. These aren't being filled during initial respiration in those 3 scenarios I just gave you. So they're constant dead spaces that, when requested to activate, can't. The airways are collapsed, the alveoli are collapsed there, and they go into spasm, reactive spasming. So examination of the entire rib cage, the first 8 sets in particular of the thoracic. So I'm going to go back. All right, does anybody here have reactive airway disease? This entire room, nobody has reactive airway disease? Come on up. You don't mind helping us here? I promise to be kind. All right. Yeah, okay. So, I'm Chris. Hi, Laura. Let's give Laura a round of applause, please. Not yet. So, Laura, how long have you been dealing with reactive airway disease? Since I was a kid. So, this little girl is still a kid. She is. She's still Has anybody nearly drowned? Anybody nearly drowned here? Anybody else? Okay. Does the fear of anoxia, is it still part of you? Are you really worried? Is that like your greatest fear, being without breath? Yeah. So an asthma attack where you can't get any more air in or out, and you are locked up and you are panicked, or you fall from a tree and you hit so hard that you lock that diaphragm and you can't get a breath in, or you have been nearly drowned and you aspirate water and you are going to die. You will never forget what anoxia feels like. And though we all have panic and all that, there is no panic like nearly dying from loss of oxygen. So what I would like to share with you today is how can we restore life, get it out of danger. What we're going to do is fill those apical lobes I just demonstrated to you. So I would like to share with you that, in gymnastics we learn how to do a back bend, all right? And if you're really good, you then do back bends across the mat. And you don't need to do that for this. But we're going to have the patient kind of like one of those Rolls-Royce emblems, we're kind of arching back. And so we're going to help the patient arch back. We're going to hold the thoracic spine segment by segment by segment, letting each rib unlock. But the golden zone is the 8th and above ribs, and in particular, the 3rd through 1st ribs. So I'm going to see what we can do to create a pillow for you. I need to go a little bit wider there. Yeah, there we go. Yeah, just fold it in half. There we go. Okay. So I'm going to have you, here's what we're going to do. I'm going to have you put your bottom right here. I'm going to support you. I'm going to put your arms over your head. I'm going to place my hands. About, fingertips about T12. And I'm going to have her take a deep breath in and out, all the way up until we get up here. Your head is going to be tilted backwards. If you got a neck strain, let me know. Okay. Now I'm going to put a mask on real quick, just because if you start coughing, I want to protect my face. All right, I knew I brought them. All right, so the patient, as they're filling their lungs, may start to cough. Your goal, though, is to have them breathe in as deep as they can. In order to protect the lower back, I'll often have patients just bend their knees so they're not hyperextending that lower back. Laura, do you have any questions for us at all? No. Okay. Now, if at any time it doesn't feel right, you're going to say something, right? Now, don't just suffer through this. I know, you're a woman. I am. No, just I'll go with that. I'm lucky to have an electric table that I can just, just goes up and down. So I'll just be on my knees for a woman again. Okay. Let's lay him back. Yeah, Laura's going to. Yeah, there we go. Okay, there we go. All right, nice deep breath in through your nose and out through your mouth. So I'm starting low so that I can also check for the crura of the diaphragm. Usually the crura of the diaphragm is at L2. We'll talk about that a little later, but I want to examine the whole respiratory mechanism because it may not just be something at the apex, but maybe something starting lower than this. So she's going to breathe nice and deep, really audible. That's it. There we go, good. So the deeper you can breathe and the louder you can exhale, the faster this will improve. Now, for all of you in the room, I want you to start taking note of the change in the air volume. Isn't that fun? So we're bringing the ribs essentially into inhalation. Look at that. Isn't that neat? Okay. You got to get deeper. You got to get deeper. I got to be. That's it. That's it. So what's happening right now is that her thoracic spines are translating laterally, the ribs are releasing, and now we are in the sweet spot. You guys hear the change? Nice deep breath. Patients will often report that I feel a coldness in my lungs, coldness in my chest. There you go. Yes. There, is that fun? Nice deep breath.
Real deep. As deep as you can.
There we go. Look at that.
Nice and deep.
Okay. So I'm using all that I can to introduce extension. Okay, there we go. Now deep breath now. Deep, deep, deep. Okay, your best breath. That's it. There we go. Okay, terrific. Okay. Thank you. Good job. Yeah, here, it's good forward, Laura. No, don't get off. No.
You sure?
Here you go. Good, laying back down. Okay, so if you're looking for a head rush, all right. So, did anybody hear the change in the lung volume at all? No? Okay, you guys could see the dynamic change in the... So, it's hard for me to do that and then have them instruct and do the breathing. I have to really concentrate on one segment at a time. This is why you need to have somebody with you to spot you, to kind of help support them, but also to coach them. The deeper you can breathe, the more the result. That's all. All righty. How you feeling now? You can sit up? Okay. How'd that feel? Very good, actually, yeah. So all of a sudden, what was really fascinating is that you heard me kept saying, oh, there we go. And I get really geeked up because all of a sudden I start feeling the tissues releasing, translating. She has a lot of restriction on the right side of her rib cage. And as she was going, it just, rib after segment just continued to translate and release, translate, release all the way up. And so, thank you very much, Larry.
Thank you.
Okay. Does anybody else have asthma? So here's the other thing. I have taken care of, I have been to LMU 3 times, but I've been to a number of different schools from California to Florida and elsewhere. Every time I do this for the students, they'll have 3 in the audience of 50, and it's wailing. You get them to have their first breath, and you can literally hear, they're wailing. They've got to leave the program. It's a very emotional thing because all of a sudden, for the first time in their life, they can breathe. So just be aware that there can be emotional discharges with this. It's all joy, but it's overwhelming. It's a shock to them because they've only known suffering. They've only known the castigation and label of why they couldn't go play with their friends because they have asthma or whatever. So life is in danger and can be saved by skill, not by force and ignorance. You must think. So heartache in the left anterior chest wall. Deep sorrow associated with the loss of a dog, home, loved one, or divorce may be present here. Patients will experience heaviness above the myocardium at the lateral 2/3 of the left clavicle line along the superior origin of the pectoralis minor. Does anybody have something they're sorrowful about? You guys are all full of gaiety and frivolity, nothing ever went wrong. Okay. So situational depression, it's treated with counseling, antidepressants, selective serotonin uptake inhibitors, cognitive behavioral therapy, neurofeedback, lifestyle modification, or you can put your hands on and get rid of all that crap. So who wants to be my test pilot? All righty. I'm Chris. Mike. Good to see you.
Good to see you too.
Everybody, this is Mike. Okay, I won't say that. I'll just. Mike's had quite a bit of a tough event. Is that okay to say?
Fine.
Okay. So, Mike, I'm going to have you lay on your back, please, and place your head here. Okay. So, I don't have a mandate for anything I'm positioning on the table. However, many times I'd like to have patients with their knees bent so the lumbar spine is flat so there's just one less tension on their body. So the left anterior chest wall is really fascinating to me because Dr. Still found that if people have substance abuse, alcoholism was the thing of his time, the 6th anterior rib was the spot he would find. I find that people who were in homes as babies of domestic abuse and alcoholism, they'll have that as well. But people who are currently heavily under the influence will have this. I'm just trying to say that just look for if you're worried about heroin abuse, polysubstance abuse, alcoholism, just have an idea, it'll show itself. I'm not going to do it to you. You.
I'm president of the Tennessee Medical Foundation, so I don't know if that shows, but I've been sober 23 years.
Yeah, I'm not gonna pull it out. I'm just trying to say to.
Okay.
We're in the heartbreak right now. I'm just incidental almost. Okay. All right. So to make a long story short, I'm gonna with every wrist, elbow, hand trauma, I'm going to examine the anterior. Can we get? No, you can't see it. Okay, this is your clavicle head right here. The clavicle head for me has 3 points of tenderness. I'll look at the superior, middle, and inferior aspect of that clavicle. Every time I go and examine an arm, I'm going to start my exam right here. I'm just incidental things. I don't want to miss a moment with you. So I don't want the heartache to be confused with an arm pain of something I didn't diagnose is what I'm trying to say. I don't want there to be scatter in the diagnosis here. So anything here at A, B, or C? A, you would know. It'd be like, So when I go to examine the anterior chest wall here, so I'm up, in fact, if it doesn't feel good at all. Just catch this right there. Mike knows extreme loss, and there's the pain. It's the superior aspect of the pectoralis minor. You guys clear on this so far, all right? Do you guys know you're not giving me any responsiveness, like I'm throwing it out there I could use? Okay, so again, the lateral 2/3, you go at the clavicle lateral 2/3 on the left side, you're going to palpate down gently the pectoralis minor origin. And so, which is worse, pain A or B? Yeah. So it's a very superior aspect, like I was saying. It's a superior aspect. There are essentially 4 attachments of that pectoralis minor. You're going to go to the superior one, lateral 2/3 of that clavicle. And Laura's going to come over to my left side. Again, you can do all of this on your own. At the same time, if you have help, share it. In this kind of a condition where people are a lot of distress, our own humanity, if you have a compassionate someone other in the room too, it only helps. Whenever we touch somebody, we're helping to let them know that they're okay, that we're welcoming them. That's why we give a handshake gently to people. We aren't trying to force our hand or push them to their knees. We're putting a handshake out there for kindness and extend, hey, I approve of you, I like you, you're good. Well, you touch somebody and they're already feeling, hey, the human connection. So press right here and just hold your head. There we go. Or, yeah, you can, however, if you want to have your legs down, that's fine. No? Okay. We're going to, all right, just go ahead and drop onto my shoulder. So I'll use my body, I'll use my shoulder, I'll use my arm so that they can just drop. Otherwise, if they're holding their neck up or whatever, they're not going to release. A nice deep breath in through your nose and out through your mouth.
Push it out. Nice and deep. And push it out.
There it is. Isn't that beautiful?
Nice deep breath in through the nose. Push it out. Nice and deep.
There we go. There it goes. 0 is no pain, 10 is the worst pain. Nothing. I gotcha. Good job. Just rest here, just rest. Okay. That was very gentle. It doesn't require force. It requires compassion. Okay, it requires being present in their space. All you're doing is you're seeing the origin of the pectoralis minor. You're taking the load off the pectoralis minor. You're wrapping them around the tender point. It seems kind of redundant and repetitive, but that's really what you're doing. You're taking the load off the areas that are guarding. So literally, the weight, people say, it feels like a weight was lifted off my chest, that I'm no longer feeling compressed or crushed by this experience. And that's what you're doing. You're in there fellowshipping with them, and you're literally helping them to get their breath again. When you get that kind of a death knell blow, you get the wind knocked out of you. Just like that kidney, the wind has been knocked out and has never been filled back up again until you do this kind of a simple maneuver.
Question.
Yes, sir.
When you're doing that, are you palpating and fixing, or are you also applying pressure?
I am palpating and adjusting. So I'm letting his head rest into me. I'm working with what I got. Again, my table is up and around. I can do all these things. And I'll just stand from above, and I can just let the head rest on my forearm. But what I'm doing, to your point, is I'm simply feeling a release, and then I'm hanging on for more. You have a very good point that I'm glad you reminded me of, and that is, so many times I will get the key lesion that someone comes in for, and I feel like a hero. I take care of the whole systemic body. I'm also a pilot, so you do a pre-flight and you check every part of that plane before you go upstairs. I'll check a body every part before I let them go. But the thing of it is, I've learned now, to your point, that I've got to hang on. Because just because I get rid of the first lesion, I'll have to hang on and wait to see if there's anything else that shows up. And that's what you're seeing here. I was waiting because something else showed up. He's also got some other heart aches that presented themselves beyond the current one. And so I had to let go of that as well. So position and adjust.
It feels much lighter there. So it's weird when I do meditation, it always seems like I was rotated to the right. And I can already tell that it seems like I'm shifting to the left. I don't know how to describe it besides that.
Okay, what he's describing here is that we need each other. I can see his blind side that he can't see. You guys get that? This is why we're married, hopefully, or whatever. We have somebody significant other. Sometimes even mom does a great job. Say, hey, honey, would you, hey, you still have toothpaste. So at any rate, by bringing him through the position he's been wanting to get to and holding him and release, all of a sudden the fascial restrictions that are deep within his body go away. And that's what he's talking about. I've been doing yoga for years, doing this white rotation, and I don't have that sketch anymore. Well, it's because he was stuck to the left. We released the restriction, and then he rotated and floated back to his neutral place finally. Great job. Thank you.
How long does it tend to hold for, or do you have them come back and?
No, we're done. Yeah. So, but to his point, I have to wait for it and then check again, make sure that there isn't something else behind it. I mean, he can also have hurt his shoulder, and there can be other things that he did in his other 30 years that have been behind the scenes. So that's just the hard thing for me is that, again, you'll feel like a hero because you took care of this big issue, but then come back next week. Here, I had a woman. She's driving 55 miles an hour, hits a 7-point buck in the rural Wisconsin road, smashes the hell out of the GMC she's in, the Suburban's trashed. She hits with such velocity, this thing takes out the radiator, shifts the motor mounts, and then causes a transmission leak. And she keeps driving the next mile until she gets to her daughter's house. She's all shook up, and because she wasn't drinking, she had grabbed the steering wheel, held on for dear life, and then took the impact all in her upper back, all throughout her thorax, and all that. So she comes to me 2 months later. She's known me. I'm like, why didn't you come to me? So she comes to me. I take care of all of these things. She leaves, and then is 5 days later in incredible pain. And I'm like, what? You're in pain? What happened? So I say, please come on in. I'm sorry. How did I miss this? I'm sorry. So she tells me, well, the pain I've got is all through here. It's right here, and it's right here. And I'm like, I didn't treat that. What, ma'am? I have her lay on the table, and I'm going, ma'am, this is a very, very old injury. It's like 50 years old. It's a really old injury. And she goes, oh, my husband and I were on a sled once, and we were going down this hill, and they said, don't go that way, but we went that way. And so we hit this jump, and we landed, and it shattered the sled. I couldn't walk for 6 weeks. Okay, so that old injury showed itself now because it wasn't manifesting, at the time of a presentation. So you'll have these things where you're like, I'm a hero, and then you feel really good about yourself. And then, because you didn't hang on long enough to understand that there was something remotely, 60 years or 50 years before all that. Okay. So treat, to know you are right and do your work accordingly. You're seeing this all day long with me, guys. I have to listen to my heart. Okay, this is the anatomy, this is the structure, this is what I have to do to take the load off the body so the body can reset the check valve. So touch of life. Does anyone know who Robert Fulford is by chance? Robert Fulford, FAO, remarkable. He was an engineer who became a physician and brought all sorts of different engineering ideas to osteopathy. Really quite a fellow. So trauma can arrest our free breathing and, in turn, will often negatively affect our life force. This can result in pain or disease, although the trauma's full consequences may not be evident until years later. Thought patterns can also disrupt our breathing and our health because the constant repetition of negative thoughts will eventually upset the body's chemistry and create restrictions of motion as perilous as those created by physical trauma. Your mind is as effective as your body in committing trauma and keeping them engaged. We saw that earlier with the heartache. This poor thing has been dealing with a heartache all this time, and it was as physical and real as any kind of punch to the chest. All right. What time is it? Okay, the sympathetic nervous system. Superior cervical ganglia, second cervical to the conus medullaris, the second lumbar vertebra. Activation of the hypothalamus or sympathetic ganglia along the spine between the ribs can trigger the stimulation of the adrenal medulla and the release of norepinephrine, which triggers the fight or flight response. The systemic response is mediated in part by the activation of the alpha adrenergic receptors, resulting in smooth muscle vasoconstriction. So a lot of these patients are having chronic vasoconstriction. It's never been released. They've had chronic guarding, chronic restriction of blood flow. So prolonged hypersympathetic responses often result in chronic worry, panic, and or anxiety. And what is the time, by the way? 20 till? Oh, this is good. This is good. I'm rolling in. So anxiety usually has a cause. I want people to understand this. Anxiety usually has a cause. They're not just, oh, they're just anxious. You know, they're just anxious people. No, there's a cause. So patients often report when asked, when were you last well? When did your anxiety start? I was 4 when my dad told me that he was leaving. Talk about a disruption. I've had these patients. I've had all this kind of stuff. It's a shock, and all of a sudden, their whole world is shattered. Ask your patients what their home life was like during their imprinting period of 0 to 3 years. In other words, so what was it like when you were 3 years old? Was your mom drinking? Was dad drinking? Was it screaming in the house? What was that like? I've had patients say, you know, immigrant families. Mom had to go to Slovakia, and I never knew where she was. Dad was German. He never really was comfortable and kind to us. You know, all these stories, you're like, oh my goodness. So a tool, ask your patient to journal for 3 minutes just before bed when the mind slows to the delta waves and the limbic system is activated. Resolution may occur and insomnia improve. All right, so right now we are in alpha theta waves. You guys are still going, what the hell is this guy about? So, but later on tonight when you're laying in bed, things slow down and you are in delta waves. So delta waves are where the limbic system, which is the, gee, I wish I had said something, or I'm really sorry that I beat the dog, whatever. So these things that we wish we had done or wish we hadn't done, I believe more usually I didn't do, so will become more manifest to us. So it's in those minutes before bed, if we can just sit and write in that calm, we can get things off our chest that are worrisome, painful, anguishing. And when so doing, we can take a breath and then go to sleep, as opposed to laying in bed for 90 minutes, perseverating, going things over and over again, or waking up at 3 o'clock in the morning with this unresolved issue. So you can't read all this, I get it, but this is one of the best diagrams I've got, the sympathetic nervous system, and I'm going to read what it shows. But basically, like I was saying, here's the superior cervical ganglia, this is the C2, all the way down to L2. All of this is the network of the sympathetic nervous system. And so what does that mean? Well, the sympathetic ganglia, the superior cervical ganglia, the middle cervical ganglia, the stellate ganglia, cervical cardiac nerves, external carotid plexus, internal carotid plexus, common carotid plexus, vertebral plexus, subclavian plexus, thoracic aortic plexus, pulmonary plexus, cardiac plexus, celiac ganglia, and the thoracic splanchnic nerves. this is really important to be able to see in your mind's eye all of these different substations of the sympathetic system. But all of these substations are all along the spine. So the sympathetic nervous systems are not necessarily down in your toe. They come from the center spot of our spines. So okay, here's the spinal cord. Spinal body above it, it's like L2 and L1. This nerve exits out between those two vertebral bodies. And laterally, here you have the sympathetic ganglia, part of the whole sympathetic system, going up parallel to the spine. So it's not in the spine, it's parallel to the spine. In some cases, there's a rib above and a rib below. This is between that spot. So far, so good? Okay. So the path to peace. In order to release the hypersympathetic response, have the patient rest supine and place your hands on either side of the second lumbar spine at the conus medullaris. Ask your patient to slowly inhale and exhale. Place your fingertips between each of the ribs near the spine and sympathetic ganglia. Perform indirect releases of the restrictions up to the cervical spine. So here we are. Here's George, and L2 at the base, and all the way up to C2 at the top. Okay? So what does that mean? Like a computer, sometimes you need to go back and shut it down, reset it. Okay? Just like you just watched the myocardium respond and the chest wall respond by simply holding the patient in a gentle position to let those nerve axes stop firing and settle down. I have used this successfully with a number of people who've had these traumatic experiences, who've lived on adrenaline for years. That's just what they know. And by simply doing this step by step, it's not an active force. It's actually being present with the patient. Placing your fingertips just gently. It's no active force. I'm not popping anything. I'm literally just in my mind's eye, dissecting through my mind's eye, looking at the splanchnics, looking at anything I can do to help stimulate the release of the sympathetic nervous system. It is not ethereal, guys. It's real. The body has spinal nerves. You guys have known the expression of like, oh, that raises the hair on my back. You guys familiar with that one? Or you were in a residency, you were scared as hell, and you had a sweaty back all day long for about 3 years? No? Okay. So, you know, the sympathetic nerves, you're always on edge. Are they going to call me out for the 9 hand signs of liver failure? Or pulmonary erythema, spiral telangiectasias? Is that all you got? Yep, that's what I got. So, at any rate, by simply having your patient rest and move all the way up. Guys, I know that somebody in the room here has anxiety. Okay, it's the number one, between depression and anxiety, like these are the most prescribed. Oh, I'm sorry, the medication for cholesterol. Those 3 medication types are the most commonly prescribed. Does anybody have an issue, or you don't need to admit anything out loud, but anybody have just they're constantly on edge? Okay, good. All righty, welcome. I'm Chris. Hi, Jeffrey. Okay, Jeffrey, would you mind telling my nephew, have I embarrassed the family? No. Okay, good. Okay. All right. So, Jeffrey, what we're going to do is I'm going to have you rest on the table. I'm going to have Laura with me as well. All you need to do is breathe gently. You don't have. This is not one where you have to be like dilating the rib cage or anything. So you're just going to rest comfortably. If you want to have your legs straight, that's fine, or knees bent, that's fine either way. And if any time there's pain or you're uncomfortable, please, someone to stop right away. You're in control. All right. So I'm just going to move our way on up. So if you have to lay on your back, feet that way, and let's get your glasses up just for a minute. Yeah. And we'll have you scoot down the table there a little bit. Okay, thank you. Actually, yeah. No, I do so many different things that without my table, I'm a little out of my element right now, that's all. Let's have you just lay down so I can see. All right. We're going to have you bring your head just to the top of the table here. So what I will do is put on a mask just because this may cause people to cough. It usually doesn't, but just in case, I don't need to catch any expectoration in my face. And they're just going to be breathing, but I'd like to have just general breathing as I'm going through this. Now, I'm going to be feeling from the kura of the diaphragm. So where our breath starts, I'm going to go down from there. And just starting there, you'll see typically 9 out of 10 patients who are suffering with these kind of distractions are going to have a, and you'll feel literally the muscles drop into your hands. The tissues will just simply unfold and fall into your fingertips. All right, Jeffrey, just have to roll towards that side a little bit. Okay, and then have you roll this other way. Okay, hold on back down. Okay. Okay. There you go, on the table. Now, I'm going to get away from it in a minute, but there's, again, because I don't have my table. Okay, go ahead and start breathing. My fingertips are just lateral to the transverse process of the spine. Okay, you feel the first release? So as you're going through this, you may feel a restriction on one side of the spine or another, and you can just simply gently shift. There you go. Do you feel it pop and release? You can simply just translate the ribs to the left or the right as he's breathing, but the patient will tell you where they need to go. You feel that other release there? Beautiful. There's your kidneys. So when I get to about T10, I'm on the adrenal glands, and I'm just above the renal arteries. And so I'm looking for this place in particular because it can be a hot zone. Again, it's the adrenal medulla that produces the norepinephrine. There. You feel that pop out on the side? And this does not require force. This requires just a monitoring hand, just listening. Here we go. So far, so good. There we go. So this may take about 8 minutes as the patient is going through these respiratory cycles, and you don't want to rush it. They're basically incidental things have come off. So far, he's had about 4 different releases that were deep as On the left side, a kidney released. On the right side, the diaphragm released. On the right side above that was where the thoracolumbar junction released. We had a hyperextension injury. Where am I stuck on? I'm sorry. Can you help me with this? Great. I'm like, why won't this slide away? There it is. So what's fascinating is that you can literally see things balancing out left to right as the tensions resolve. And do you guys see his complexion? He was a little bit paler than this when he first laid down. And so as the calm comes up, all of a sudden vasodilators come about. One thing's really wild is, you ever seen those guys who come to your office and they're so anxious that the pupils are really dilated? You can see very little bit of the iris. Well, those are your hypersympathetic, fight or flight guys who are trying to smile throughout their day, but they're really scared, they're upset. There's a whole lot, but it's amazing. Just look at their eyes. You can read a lot just by looking at the pupils. And a lot of us who are distressed will have very large pupils. There, isn't that neat? So this does not require force. This just requires listening. And this is a skill that everyone in this room can develop. This is not rocket science. It's just kindness. It is just the application of your anatomy. This is beautiful, by the way. I just so much love being on the mechanism when you can just feel people coming to peace and you feel things just dropping and relaxing. I think this is why we like back rubs when we were kids. Yay. Look at that. So I'm up now on C2. Just getting this one. There it is. And then into your ear. All right, there we go. Good job. You can rest here for a minute. Yeah. So,
Question?
yes, sir.
A lot of times people don't get the gift of someone listening. You encourage them to talk while you're doing that so they feel like they're being listened to or that they are being listened to.
To your point, that's a good one. A lot of people are so mesmerized by the experience, they just want to receive it. Okay. Yeah. Okay. Okay. Do you want to go back to the seat or just sit here for a minute?
I can go back to see.
Okay. All right. So back to your issue, there is a lot of emotional discharge, just like with releasing somebody's lungs that have been trapped for asthma all their life. A lot of this is like, I haven't been able to breathe. Like I haven't. Okay, so I actually took this out of the slide, but the reason I get doing this is because I've had a number of patients tell me, Dr. Stephenson, I've never known peace. I've never known peace. And so as they're laying here reflectively receiving this, just gentle, there's no active force for me. I am just monitoring. I'm just listening. And maybe my hands go a little bit where, the body will shift and you just kind of follow where the body wants to go. You're not, there's no active process on your part. You're simply letting it go. Okay. Okay, Okay, guys, this stuff does take a toll on me too. I love this, but it's just emotional. It's hard for me. I can tell the sorrows.
That's a great question about treatment. Has there been any theory given to treating sympathetics patient prone instead of supine? I know it affects the breathing.
I've never seen this. I'm showing you guys this. I've never seen it. My patients have shown me this, and when I studied anatomy and studied them, it's easier for me to let the sympathetics be right here because I can just feel them as opposed to going, for me, if I'm above, well, then the sympathetics are dropped forward and harder to get to. So anxiety, gut-wrenching experience. In case of anxiety, please consider evaluating the vascular and neurologic origins of the solar plexus. This is kind of outside of this. In order to address anxiety fully, you don't just address it like I did. This is just one more. I want to make sure we include this. So the celiac trunk, the first artery off the aorta of the abdomen, perfuses the spleen, stomach, gallbladder, and liver. So the celiac trunk is right here, just to the left of the linea alba. And then the nerves of the abdominal vertebral ganglia, the celiac plexus, superior and inferior mesenteric ganglia. So what I will do is place my hands just under the xiphoid, feeling for the aorta and the first branch, the celiac trunk. And then underneath, I will look for the falciform ligament, which is the ligament that suspends the liver and the gallbladder. And right inside of that is the celiac plexus, which is the nerve bundle that will then innervate the pancreas, the liver, the shoulder, so the gallbladder. This is the nerve axis that, when irritated, will go up to the right shoulder, causing right shoulder pain. It's actually the pancreas in trouble. And then chronic anxiety may cause further GI symptoms. The superior mesenteric artery produces the pancreas, the second half of the duodenum, and the entire 31 feet of the small bowel and part of the colon. And you'll address cranial nerves 10, the vagus, and the enteric nerve. So I'll have my hands right on the midline. So the superior mesenteric artery is you've got the umbilicus and the xiphoid process. In between that is the superior mesenteric artery. I'll have my hand placed there. I'll hold the base of the skull, but actually I'm looking for the 10th cranial nerves on the sides of the vagus in my left hand. Position, hold and release, and let it go. So this is a part of the chronic anxiety. This is why I don't use PPIs or any other agents to stimulate the bowel or enhance the bowel's function until I release the blood flow. Once I release the blood flow, all of a sudden the environment changes and the body goes back to homeostatic balance. So you will know that you did it right when the patient says, "This is the first time in my life that I have known peace." So injury, hypoperfusion, microclimates. When blood and lymphatics flow freely, the tissues can perform their physiologic functions without impedance. With the occurrence of trauma, physical or emotional, the tissues contract, twist, and compress. Again, any kind of trauma, I'm going to guard. It's that guarding that gets us in trouble on a prolonged basis. The fluid flow becomes obstructed. Microclimates and underperfusion result and are considered to be a significant contributor to the onset of dis-ease. Cancers develop in anaerobic environments. I do a lot of work in oncology, so it's that. Releasing fascial obstructions allows for the unrestricted reperfusion and restoration of chronic injuries. So live osteopathically. I'm just going to give you a little philosophy to wrap up. In osteopathy, we have the tree of life and the living man in it. Our science sees him. Our science has proven him to be a living man, proven him to be the work of a living God, a wise God, whose works are alive and show wisdom and form and purposes. We must learn that nature, osteopathy, means wisdom, it means mental ability, means business honestly, and we must not disobey its teachings. Nature never made a philosopher. He made man to learn and act. His last words written were, "I have given permanent relief to many patients and some relief to all." His great books, he wrote 4 of them. I would encourage you to read them. I was not able to really read them or have time as a student or resident. He has become my mentor over these years. It seems like Scripture, you go back and you reread it a different time and it speaks to you differently. And then one of the most profound biographies by John Lewis is from England. It's called From Dry Bone to Living Man. It's just a remarkable biography. So thank you to the people who inspired me to learn their mechanism and dig on to serve them better. That's an old classic DO thing. So the Atlas of Anatomy, 4th edition, Themes Medical Publishers to the right there, to the left. It's pretty cool. The first edition has been a gift to my son from the senior production editor, Elsie Chang. I saved her dad's life in a 4 a.m. heroic cardiac issue. It's pretty cool. The doctor who was doing the aortic replacement, he became hypercoagulated. They couldn't reverse the coagulation until FFP was a good idea. Internist. See? Internist. And then George, a gift from my dad, named after Still's Bag of Bones. Here's myself and AT. So thank you very much for your time today. Appreciate it.